This time, the antibiotic we talk about is clindamycin. It's a family of the lincosamide family. It binds to the 50th subunit of the ribosome and inhibits protein synthesis. If you look at the spectrum, it has activity against gram-positive aerobes, including MRSA, and anaerobes, both gram-negative and gram-positive. It is available for topical application, mainly for acne and bacterial vaginosis. Clinically, we can use it for septicemia, skin and soft tissue infections, intra-abdominal infection, pneumonia, bone and joint infections, gynecological infections, head and neck infections, but it is not good for meningitis because there the penetration is poor. So you should have another choice when meningitis is of concern. The dosing for the aerobic cocci is around 600 to 1200 milligrams per day, generally given as two divided doses. Severe infections or those due to Bacteroides fragilis, Peptococcus and Clostridia non-difficile type, the dose is 1200 to 2700 milligrams per day, and one may go up to as much as 4800 milligrams a day. Can be used as a continuous infusion after the first dose. There is something which may help us pharmacokinetically. And it has an oral formulation which has excellent bioavailability. So dose for dose you can change them. It is excreted and metabolized by the liver and has biliary excretion which is very prolonged. And so it has a significant effect on the bowel organism and is one of the antibiotics with highest propensity for C. difficile infection. One striking point about the antibiotic, it may decrease the toxin production by Staphylococcus aureus even at some MIC levels, and may be a part of a combination therapy for skin and soft tissue infection to decrease the toxin load in anaerobic lung infections, and it may be used as an add-on therapy in these conditions. What are the major concerns with clindamycin? C. difficile. The asymptomatic carrier rate is also very high, and development of a clinically significant C. difficile infection is also very high. And this can happen even after weeks of discontinuation of the antibiotic because we say it has a prolonged hepatobiliary secretion. There is a high incidence of rash, and it has no activity as against enterococci, so that is one infection where it should be avoided. Now, clinically, where do we apply it to use? Where mixed aerobic gram-positive and anaerobes are involved, that is one condition, or short-term as combination therapy for reduction of the toxin production. And if you look at the anaerobic coverage, you have metronidazole as an alternative. For gram-positive, you have a lot of other alternatives. So we are going to use, this antibiotic for a very special purpose. Maybe it's one of those which is a reserved antibiotic in the intensive care because of the significant incidence of C. difficile infection. The another striking point is since both macrolides and clindamycin act via 50S ribosome, there could be some antagonism when used together. So this should always be noted, this kind of antibiotic interaction. And also antibiotics which act through the 50S ribosome, like the macrolides and the streptogramin and clindamycin, they can have shared resistance. So that should also be kept in mind. So we have clindamycin which can be used as an MRSA agent, otherwise has good cover against gram-positive cocci, has activity against anaerobes, and we should be very clear about the clinical situations where we want to use it, always keeping in mind if there is a better alternative.